be ready to go. Please mute your phones, but pay attention if somebody, and that goes to me too. If you need to text, let us know.
I do believe the stream should be starting up now.
Good morning, everyone who may be participating with us on YouTube today. This is the Select Committee on Mental Health that's been put together to consist of people from the Joint Appropriations and the Labor, Health, and Social Service Committee to address mental health issues in the state. We have this is our third meeting, wherein we have been the previous two meetings have been having conversations on the delivery of mental health through our community mental health programs and providers in the state. We're going to follow that discussion some today, and then as you've looked at our agenda on the that's provided by LSO, we're going to be going into some adolescent mental health discussion today, which is a little bit of new ground for some of us, and address those issues as well. So John, our LSO staff, John Brody, would you take roll, please?
Yes, Mr. Chairman. Senator Bouchard.
Here.
Senator Guru.
Here.
Senator Schuler.
Here.
Representative Barlow.
Here.
Representative Olson.
Here.
Representative Wilson.
Here.
Co-Chairman Kinski.
Here.
Co-Chairman Larson.
Here. So committee, as we've contemplated the discussion on how we use the funds from the state that goes into the mental health supports and contracts of the community mental health providers, the question keeps coming up as what is the state's role? The Department of Health, as they've been preparing to help us through this, and as they've taking this issue before the Labor and Health Committee in previous times, they went through an exercise internally to identify kind of how where they felt that these who should be receiving these services. I participated with the Department of Health and some of the representatives from our community mental health providers, WAMSAC, and their in a meeting where they went through a similar exercise, and it's interesting to see how these populations fall into various buckets, and I think and so we're going to go through that exercise today, and we're going to turn the time over to the Department of Health. Jerry Hendricks is going to take control of the wheel here, and she'll be asking each of us questions on who we feel the state should be serving. That doesn't mean that our community mental health providers aren't already providing those helps in those populations, but just who do we see in the state that is worthy of those services in our opinions, and then they'll kind of go through an exercise of categorizing those, and we'll have some follow-up discussion after that. So we're going to give the reins over to Jerry and let her take that. I'll go all mute, and then we'll let her kind of drive that show, Elizabeth. So Jerry, it's yours.
Thank you, Mr. Chairman. My name is Jerry Hendricks, and I'm the Policy Administrator for the Wyoming Department of Health. I'm first going to have Stefan Johansson, our Deputy Director, give a brief introduction of the purpose of this exercise, and then I will facilitate us through some of the exercises we have prepared.
Thanks, Jerry, and Mr. Chairman and members of the committee. I'll be very brief. My name is Stefan Johansson, Deputy Director for the Health Department. At the request of both Chairman Larson and Co-Chairman Kinski, we really developed this exercise to go through internally as well as with some of our external stakeholders over the past year, as community mental health and substance abuse changes, reforms, whatever you want to call it, were being discussed at multiple levels of the legislature and the executive branch. So very similar to the facilities task force from the past, 4 or 5 years. We kind of modeled it off of that, where before there's any, preconceived notions or legislative directions, executive branch changes to contracts, where we really found success with remissioning our 2 safety net behavioral health facilities was in thoroughly going through an exercise that helps us define the role of the state, helps us prioritize populations, and then maybe could help this committee or others address what has been articulated as a potential lack of missioning in this system, both from a legislative perspective and an executive branch, contracting perspective. What problems are we trying to solve? What outcomes are we trying to achieve? And who are we trying to cover with the general fund dollars that go through this system? So really what I'll do is hand it over to Jerry. I'm not sure how many of you have worked with Jerry. She's relatively new to the department, past several years, a very talented attorney, manages our Department of Health Policy Unit, as well as our Office of Privacy and Security and Contracts. So she already wears a lot of different hats in the committee, but also in a previous life was a very good facilitator that we worked with in the Department of Health. So we think this could be a fruitful exercise, and hope that you'll engage like we did, both internal to the director's office, our behavioral health division, as well as what Representative Larson mentioned with our provider groups. And again, always more can be done when you have these discussions, but I think this could be a meaningful first step. So I'm going to hand it over to Jerry. Franz Fuchs is also on the line and will be able to share his screen. Similar to what we did internally and with the provider group, we'll try to capture visually what the brainstorm is producing. Representative Larson, sorry, I feel awkward calling on the chairman of a committee.
Looks like you're on mute.
I think you're on mute, sir.
Thank you. Stephen or Jerry, maybe as you get going in there, it might be fair to the members of the committee to just kind of share what populations our community mental health providers serve now. So as we contemplate that a little bit. So if you kind of have a feel for that, it would be helpful.
Sure, Representative, Mr. Chairman and members of the committee. It really is kind of the full gamut of populations and services, but not the same in every community. So we have a wide range of general access, low acuity populations, as well as populations that might have more of an acute crisis need or more acute substance abuse needs. So it really does kind of run the gamut from everything from a lower acuity general access population to higher needs kids, higher needs families, higher needs mental health and substance abuse clients, as well as kind of a peppering of different types of clientele in the residential services as well. So what we've kind of communicated prior is if you think, just to oversimplify it a little bit, if you think of a continuum of mental health and substance abuse policy, where on the one extreme you would have just a pass-through kind of funding system where the dollars come in from the legislature to the department and we pass them through to the providers. That's not to overly simplify, but that's similar to how we fund our senior centers. There are, obviously contract and federal provisions that are in there, but it is, especially with the Senior Services Board, more of a pass-through type of funding model. Then on the other extreme into the continuum, you have very strict eligibility or insurance type systems like we have in Medicaid, where someone has to meet a categorical and a financial eligibility criteria, or in the case of the waivers, meet a relatively strict clinical criteria to be part of that system. And we like to think that our community mental health and substance abuse system is somewhere in the middle. But again, what's been articulated by folks on this committee and others is that mission, both in statute, in general perception, is not as clear as maybe it could be. So what is the role of the state? Are we trying to shoot more for a pass-through funding type of model or a very strict eligibility safety net type of role. And if we're somewhere in the middle, where does this committee and others in the legislature, our state policymakers, what's the preference to move on that continuum? And again, no implicit bias or preference on our part. That's really why we have developed this exercise. So, Mr. Chairman, I don't know if that answers your question, but that's kind of my take on it. Okay, well, Jerry and Franz, I will kick it over to you and turn my ugly mug off of the screen here. So take it away, Jerry.
Okay, thank you. So first, I just wanted to give a quick overview of the exercises that we have planned to brainstorm and move us to see if we can find some consensus on what is the role of the state and what are these populations to serve. Once that's defined, then, then the committee would be able to have the tools necessary to work on legislation to operationalize the mission with things like eligibility that Stefan had just mentioned. So quickly, we will have a brief discussion on the role of the state as Stefan just described, and then we'll move into an exercise where we will brainstorm and categorize populations to be served in our mental health substance abuse system. And then we will run through an exercise where we introduce resource constraints, and it will help us determine how we would prioritize those groups. And then at the end of our exercise, we will sort of revisit where we are all at with where the role of the state is after gone through that exercise. So Franz is projecting his screen. Stefan did a really excellent job sort of describing the two spectrums of sort of a general access system, where again, you can look at a general access system as just basically a pass-through of state funds to providers, very little oversight or say on who those funds are going to or how they're going to be expended. And then sort of on the other extreme of the spectrum is the safety net, where we have, maybe outcomes monitoring, and we have those priority populations defined. So right now we are somewhere in the middle. And at this point, would like to have a brief discussion of and open it up to members of the committee of where you think we should be on this spectrum. Right now, we're somewhere in the middle. Is the role of the state more general access, or is it more towards that more focused safety net? So with that, I'll open up to members of the committee for comments.
Okay, I'll start. If you're waiting for somebody, Jerry.
Yes, please.
Okay. Well, we're going to go through this and then talk about some of the constraints, but I think generally speaking, where we are now is pretty good. But I'd like to, the hardest part, and I know I believe it's Senator Bouchard and I served together on management audit, and we tried to do a management audit on the CHINS program last year, and we really couldn't because everything is so siloed in how the goods are delivered, whether it's through the court system or through HIPAA restraints and everything else. No one seems to be able to talk to each other to be able to say how we're getting how well we're doing. So I guess what I would say, I think we're about right, but I'd like to see us get more through technology and however we can get more to be able to measure deliverables all the way through the spectrum. And so we can chart and see how we're doing, because we know that the budget's going to push us that way. Budget constraints are going to push us that way. So it's going to be more, to me, very pivotal that we be able to measure outcomes more, because we're not going to have the bandwidth on funding. So does that get you started?
Yes, thank you. Any other comments on sort of where we should move along this spectrum of the role of the state? And I apologize, I can't see everyone up on my screen, so I hope I don't miss anyone if you're raising a hand.
Well, I'll just call on myself then.
Thank you.
Used to being called upon. I think that given the resource limitations, to me, it's pretty clear that we need to move a lot more toward the safety net side. My mantra, so to speak, during this meeting and during session is just going to be, and I'm moving slightly sideways here, but that there are services where cutting them to save a penny now ends up being pound foolish later. So I think the focus that I'm going to have on services that we provide is areas where a lack of services a lack of services will impact all people as individuals, obviously, but where the lack of services then greatly impacts communities and state budgets. So as you see on the screen, the Title 25, just general inpatient commitment at Evanston, the corrections folks, the cost of people who are either in those systems or at risk, significant risk for being at those systems. I feel like that is where we really are going to need to focus. As far as the state infrastructure required, we need to make sure that we don't push so much paperwork burden on the mental health providers. You look at just physicians and all in the community, and we've given in so much electronic health record and insurance billing that they have multiple staff members just to do that. So we need to make sure that in some way we don't overwhelm the providers with paperwork instead of providing care. But yeah, that's a good place for my dot.
Thank you. And as you can see, we're kind of taking an informal sort of straw poll of where individuals are landing. So then at the end of the exercise, we'll be able to see if we've moved or if there's consensus on the role of the state. So Representative Olson?
Yeah, I guess I'll jump in, and I guess I would put my green dot slightly over the first green dot, moving to the right on the safety net, and I wouldn't go to the extreme of the safety net side. And let me explain that. So my struggle here is, one, I take into consideration the state budget constraints, and those are obvious to me. But the thing that I think about is some of our federal, over the last, I guess, well, now it's been almost 10 years, but over the last 10 years, we've seen a lot of reform at the federal level. And one of the major reforms that our country underwent was parity laws. And so I think about parity laws at the federal level and how they apply to insurance. And if somebody has private insurance, a parity law doesn't allow that insurance to discriminate in this particular area, in mental health and substance use. Parity laws don't allow an insurance company to discriminate based on populations and priority. So whether that's a mental illness or move up the scale to physical disorders and diseases, serious mental illness, substance use, whatever it may be. So it requires parity across populations of people and across populations of service. And so then I think about that, and I think about the state's role. And then as the state, if that's the requirement on someone who has insurance, and if the state is going to provide access to mental health and substance use treatment for adolescents, for underserved populations, for offenders in our DOC, for impoverished, vulnerable adults, etc. So you go down the list, and if we are providing services to those without insurance, and we don't require parity at what we provide, so we only focus on serving high needs clients, for example, just looking at the first bullet point, then it seems fundamentally unfair to me that someone with that the insurance companies would have that same constraint, but not the state. And so I struggle with that, but I do move my dot to the right on that safety net, because I do think when we talk about general, at least when I think about general access, I'm thinking about adolescents, I'm thinking about dependent adults, I'm thinking about impoverished individuals who couldn't otherwise have access to private insurance. Those are the individuals I'm thinking of the state serving. So those are my thoughts.
Thank you. And I would encourage you to jot those down. Our next activity will be to sort of categorize. So you just identified a number of possible categories of populations to be served. But before we move on to that step, let me check to see who else. Chairman Larson.
Well, thanks, Jerry. I thought Representative Olson's comments are right to the point of why we're having this exercise and why we're having this subcommittee in reality, is because I think that there's populations, in my opinion, out there that the state should be serving better with mental health services, and we're not, in the parity that is currently being administered probably is lacking some. And so I think I'm over there with Sue Wilson on that safety net side, because I want to ensure that we do have parity on those populations, like our seriously persistent mental illness people who are indigent in the community, and we'll get into that more later. I also think it's important, or I would like to point out that in this discussion, I think the graph that you have here is important, because this would reflect that we're saying that the role of the state is not to create a new system to take over the administration or the services of mental health, but to keep that in place with community mental health contracts that we have around the state. And I agree with that. But then to give those community mental health providers a little more direction, much like we did when some of us first came into the legislature and we looked at long-term care. And that is, if we can determine a little better whom these services should reflect to, then perhaps we can incentivize more services to some of these really underserved people to improve the parity that Representative Olson was referring to. And so I think as we get over there and identify who those are, then perhaps we can incentivize through perhaps a higher reimbursement rate or something. How do we better use those funds that are going to be available to make sure that we serve those people and keep them from adversely impacting other resources in the state?
Thank you.
Chairman Barlow had his hand up, Jerry.
Oh, yes, please go ahead.
Thank you very much. So this is Eric. I guess I can't put a dot on the graph because I think there's important things at both ends. So I'll speak to two of them. One, we've always talked about a continuum of care, and I guess that would mean it's linear, and I don't know that that is accurate enough. So when I think about the focus, the high needs focus, that's Title 25, Title 7, Department of Corrections, Youth, Adolescent. I'd also say there's some things that we should be doing the general access or the general prevention side, such as CIT training for law enforcement, such as crisis stabilization, at least regional crisis stabilization, so that whether it's coming out of the private sector or if it's a state-funded program, they would have, those would benefit all citizens that may be in a challenging place. And then we so those resources cover the entire gamut. And then we have other resources, i.e. through our community mental health centers, that are more focused. I would add to that though, that communities are different. Some communities will have a much different indigent population where severe mental illness would be may be greater in that community, and others may have a lack of private providers. So just basic services may be of the greatest value there. So I don't know where I guess I fall in the middle, because I think there's both important things on both ends that we still can prioritize in this system, but they're not all within the substance mental health system or the community mental health system. Some of them are more systematic things that I think we could use those substance abuse and mental health dollars to. CIT training, crisis stabilization. So there's kind of infrastructure, they're kind of general application, but hopefully they cut down on the other end as well. So I guess maybe I fall in the closer to the middle, but for those reasons, thank you.
Thank you, Representative Barlow.
Jerry,
Yes.
so I would put my dot on the far right-hand side. I have to start out by saying, though, I think this chart is a little bit of a false dichotomy, because it carries the implication that if we just change the mission of the community mental health centers from general access to safety net only, that somehow we're going to save money, and I don't think that's the case. I think that when the community mental health centers first started up in Wyoming, there were just not a whole lot of private mental health system, period. When this thing was passed by Kennedy in '63, I think the Northern Wyoming Mental Health Center opened up, late '60s, and there just were not mental health providers in town. There weren't even surgeons, for crying out loud. And now all that's changed. And so I think what you find is that the general access population that has insurance or resources is going to the private mental health providers, and their needs are satisfied there. Or if their acuity gets to the point that those folks can't take care of it, then they fall back to the system. So I guess what I'm saying is we could declare that we're going to be safety net only. I don't expect that we'd save a whole lot of money. And in fact, if we did it wrong, I think we're going to lose a lot of money. So, because I think in reality, most of what they do is already safety net. I think that if we had the data, I'd like to know of the current population base of the mental health centers, how many are already this high need population. And then in the ideal world, we would have, and I don't know how you would ever get it without overburdening them. And I share Representative Wilson's caution about creating a data nightmare. But if you cramp down on the community mental health centers and overwhelm them with paperwork and eligibility, those patients don't go away. They just pop up in the more expensive end of the system. So your first paragraph there is reducing the burden on other state systems. That's important. The second paragraph, pay for performance. I share Representative Wilson's caution about that. There's some of these populations, your performance is, do they stay on their meds and not show up at the ER? That's your plan of care. I mean, some of these folks just, that's where they are in their mental health status. The plan of care might be just that, they're not under a bridge, or they don't end up going back to jail. So the billing, the eligibility verification, the tracking outcomes, I think what the misfire we had with Qualis is a shot across the bow, imposing a 20 limit visit on every patient without a more nuanced approach of saying some of these folks are just lifetime, and our only expectation is that not that they're going to get significantly better, but they'll be stabilized. And that's what Representative Barlow is talking about, is the crisis stabilization. So my highest priority populations would be those who are at risk of popping up elsewhere in the system if they're not maintained. And so that would be the seriously mentally ill, that need to stay on their meds if that's the appropriate plan of treatment, the populations that are at risk of going to jail or being reincarcerated, putting their families on welfare. So, and I'm not a bleeding heart on these folks. They need intervention. They need monitoring, whether it's continuous transdermal monitoring or 24/7 drug and alcohol monitoring. They need something to keep them on the straight and narrow while they're receiving their treatment. I worry that we saw, I think it was 4 or 5 years ago, Representative Barlow or Sue may remember, we really cut the amount of substance abuse funding in the prison system. And it didn't take but a year or two before we saw an immediate rise in recidivism. So it's a false economy. I think our focus should be on making sure that more of these folks get channeled into the community mental health center and that we don't create too much of a paperwork barrier. So in my way of thinking, if we were starting the mental health centers today, we would, with the budget we have, we would say all we can prioritize is safety net. And that's where I put my dot. Thank you.
Okay, thank you. Thank you, Chairman Kinski, for your good feedback. Appreciate those comments. It looks like Senator Schuler, do you have any comments you'd like to add?
Thank you. Yeah, I think I'm probably somewhere between our current system where we are and the safety net. Not to be, too at odds with either group, because I feel like there's some pretty good discussion both ways. What we see a lot in our community, obviously, are transition issues with folks, coming out of the state hospital and either not getting the treatment they need or slipping through the cracks. I think obviously with the Life Resource Center, coming on board in the next little while, I think that will help us considerably. But we end up having a lot of folks that end up either in jail or at our crisis center, or maybe should go back to the state hospital sometimes because we don't have the kind of follow-up that we need necessarily with all of our community resources. So I'm somewhere in between there, but I think the discussion, I could go either way a little bit depending on how things go today. Thank you.
Thank you. Thank you for your feedback. Senator Bouchard, before we move on, do you have any comments to add?
Yeah, thank you. I can't argue with a lot of the points where everybody's put the dots, but there's just a lot of complexities here depending on what situation we're dealing with. When we look at corrections, we look at it's all safety net because they're captured, they're in the system. Even when they're out of the system, or let's say on a release, they still have expectations especially when it's an addictions issue. And I think some of what I see going on in Wyoming is similar to what I see in other states where they've made so many mistakes on addiction services that the problem turns worse and it becomes a homeless problem, and it just turns into a lack of the ability for people to function properly because of addictions. And so I have a real hard time looking at this chart and saying, hey, we've got just one, let's put a dot somewhere and fix something. I think the problem is systemic. I think that we have a hard time with new ideas. We have a hard time trying to really look at addiction problems and trying to fix them. And this stuff costs a lot of money going down the road if we don't get ahead of it. And as you see more legalization happen, I think you'll see more. I think Denver is having a serious problem down there right now. And it's turned into homelessness. It's money that they've spent millions upon millions upon millions, and nothing's changed. And all the time that they've had this addictions population that's even living in the streets. So so that's where I'm just having a hard time saying that we're going to put a dot and fix something. I think we need to go back to the systems that we're implementing and be on the cutting edge.
Well, thank you. Thank you, Senator. And I just thank you for all your feedback. I believe we were able to hear comments from everyone. I did just want to say that this chart certainly is oversimplified, but I do appreciate you giving your thoughts and feedback. This is as a tool that we can use to frame the issue and have a discussion. Certainly the mental health substance abuse system is very nuanced, very multifaceted, and much more complex than this simple spectrum chart that we have. But I think that we had some good feedback, and I think that we are ready to move on to our next step in our process that some of you have already made some great comments on. And this is that we are going to brainstorm the different populations to be served. So in order to create policy or draft legislation, if this committee decides to move that way, we need to define who it is we are serving. So I would encourage you all to take a couple minutes and brainstorm on your own, jot down some of the populations that a few of you have already mentioned, who are all the populations to be served, and then we'll come back and share those and get those up on our whiteboard. So just take a couple minutes to brainstorm, and then we will share. While you're all brainstorming, I just want to mention that these categories don't necessarily have to be clinical categories or any sort of official definition. It can just be any population that that may have a need for mental health substance abuse. And so just wanted to let you know to be free and open with all the different populations you're thinking of populations to be served with state dollars. And with that, let me know if anybody would be willing to start sharing the populations. Representative Barlow.
Sure, I think I kind of gave a prelude to this previously, but I think anyone that's already part of a state program system, whether it's Department of Corrections, as Senator Kinski mentioned, or Title 25, Title 7, any of those, I think that's a continuum of care, or circle of care, that this seems like an automatic place where they would be eligible. I think we're talking about an eligibility, or the priority of eligibility. That would be one that to me is automatic, that they would be there. The second one is unserved or underserved. And I'll take a couple things. I think indigent has already been talked about, folks that just don't have any means. Unemployed or underemployed. In my community, we lost numerous jobs and still losing jobs in some of the mineral industry, placing strains on families who lose health insurance. So having some kind of eligibility for those folks that are going through, not just eligibility based on income, I guess is what it would be, or loss of income in the case of these recent losses. So those would be, to my view, those would be the two categories. One is unserved or lack of care, loss of service, and the other would be those that need just a continuing care to the point that some other may. So those would be the two I'd start with. Thank you.
Thank you. Senator Bouchard. Oh, I'm sorry. I'm sorry, I'm having a little trouble. Sorry, Chairman Larson, did you want to go ahead?
I will. I'm not trying to jump in front of Senator Bouchard. Senator Bouchard, give me your okay here. It looks like I'm all right. So I would. So as I look at populations that we ought to be providing mental health services to, I agree with Representative Barlow in that those individuals who are served by, we've said some sort of court decree, whether that be Title 25, Title 7, or correctional. And part of that is diversion. If we can divert them away from going into a facility such as being titled into Title 25, and of course on the back end, bringing them back into the community and preventing recidivism. So providing ongoing services there until that is under control. And I don't know if Representative Barlow, I think that all of this kind of is inclusive of the gatekeeping intent. So just to put that in there, so that I think that we need to be providing that gatekeeping service in our system. I think that the indigent population, particularly those, the SPMI, serious persistent mental illness folks who maybe be in our community, as Senator Kinski pointed out, Co-Chairman Kinski says, making sure that we keep them on their medications out of the emergency room and out of the other institutions would be a very important function to do that. I think our high needs children who are at risk of some sort of intervention from the court system as well fits into that for these children and their families. I think, and also I think our crisis, our psychiatric crisis stabilization that we see come into our local hospitals, and how we can deal with those. And so, Jerry, those are kind of the. I know that there's more populations out there, but those are the ones that I think were really important.
Thank you, Chairman Larson. And just as a point of clarification, with gatekeeping, is that specific to a particular population?
Well, it would certainly be more in line with our Title 25, trying to divert people from going into the state hospital and doing what we in incentivizing their community mental health providers to take advantage of them locally rather than going into a facility. And it may be a less amount of time. And of course, along with that, I think we need to clarify what we would expect if we were expecting our community mental health contracts to provide gatekeeping responsibilities, or whatever name we change that to, that we would clarify what our intent there is.
Okay, thank you.
And Jerry, can I? Sorry.
Please.
So on the SPMI bunch, I think of the patient-centered medical home. Where we're trying to maintain people and prevent them from coming into the hospitals. Something similar to that approach is, I guess, what I kind of see as an important service that the community mental health providers would provide. I'll shut up.
Okay, thank you, Chairman Larson, for your feedback. I believe I saw Representative Olson's hand. Do you want to go ahead with your feedback?
Yeah, sure. Thank you. Well, I mean, this list is getting pretty comprehensive, and I see the world almost, I guess it's almost bifurcated how you have it on your sheet, a left side and a right side. And I think a lot has been said about the Department of Corrections, those with court orders, family services. that's a huge world for me. I wouldn't add a whole lot more to that other than that's kind of on the, I would consider it more on the back end. You have somebody who and what I mean by that is it's responsive. So it's not necessarily proactive, but it's responsive. Somebody has been placed into our systems, or somebody's families, et cetera. And now we're responding, but being responsive still has an element to proactiveness to it, in that I believe that these, at least in the incarceration system, these are alternatives to incarceration. If we, not just recidivism, we keep talking about that, but it's also important to understand that these are actually alternatives, that if we can get, nonviolent offenders treated for mental health and substance use upfront and heavy, then we don't have to necessarily send someone off to prison. So we may spend some time in a county jail at best. And so we reduce incarceration, not just recidivism. So on the left side, really important. But then on the right side, I would echo the comments on the unemployed, the underemployed, the indigent, and adolescents who aren't necessarily in a system with a court order, but adolescents, adolescents in general who are going to need access to mental health treatment and to potentially the substance use treatment. And especially, Senator Bouchard said earlier, as laws change and our perception of substances change, the biggest impact I think we would see is going to be among adolescents. It's going to be in our junior highs and our high schools. And so that side, the right side of the sheet, I see as being more proactive. So we're trying to get to people before they enter a court order or a system. I'm not sure how our current system really plays to those individuals, but I think when I go back to the previous screen, for example, and we're looking at the spectrum and the general access, to me, if we move that dot too far to the right on the spectrum, we're really on the left side of this sheet, and we're very reactive now. And we're providing that safety net. And so it's harder to get out in front of individuals who may not be in a system, because it's harder to see them, that they exist and that they need services. But both sides are important to me.
Thank you. Thank you for that feedback. Let's see. Senator Guru.
Yeah, I don't have much to add. I definitely have to, take care of the crisis and the statutory stuff that, everybody's talked about. Adolescents, that's, for the same reason, I think that is important, as right at the top of my list. I also too like to talk, and I don't want to lose those, some of the local programming that we do, whether it's the group homes or the clubhouse model, some of these other things that I think could help with with some of these maintenance issues. Somehow, we write down all this stuff, but then we're going to have this budget deal where we're going to have to make all these cuts and figure out how we're going to do that. I don't want to lose sight of trying, as Senator Bouchard was talking about too, is trying to think outside the box with some of these local programs that might be able to pick up some of these functions. And I say that, I know, because in my community, we have more opportunities for that. But I also think that some of the things that we're doing actually have some applicability statewide. So I'd throw that in there somewhere. And I also wanted to, I guess, correct. I said something that Representative Wilson said. I hope I didn't give the impression that I was trying to create more paperwork. I was just trying to create more communication between the left and the right side about how we're handling this, because sometimes I think that we leave ourselves open to undue cost by not communicating about how we're handling, especially youth, as we go through these Title 25 cases and things like that, if that makes sense.
Yes, thank you. Thank you for that feedback. Senator Schuler, do you have any other populations to add?
Yeah, I actually really had two that I wanted to focus on, and we've mentioned the adolescents. We're still having some issues around the state with suicides with our younger kids, and we just had an 8th grader here just a couple weeks ago that shot himself. And I mean, I've seen 2 or 3. I mean, we've had 2 or 3 just in recent months. I think the suicide hotline is going to help, but we need to do some other things proactively to help prevent that. So I think 2 or 3 of you mentioned the adolescents that are in need. But I also wanted to just mention, I think we have in our unserved area, I think our seniors, maybe we need to take a look at our senior citizens, because, and I know a lot of it has to do with COVID, but I deliver Meals on Wheels 1 day a week, and they're really having lots and lots of issues because they can't go to the senior centers, and I think they feel like they've just been left behind. And we're seeing a lot of depression and a lot of issues there. And maybe it's not COVID, maybe it's always been there. We just haven't served them as well as maybe we should have. So I wanted to add that. Thank you.
Thank you. Representative Wilson, do you have any additional populations that are not named up here that you'd like to add?
Well, so mostly there's overlap, but if I could just kind of talk through what I was thinking, and I'm going to give you what my list started to be, and then I circled back and I wasn't sure. There are some, I don't want to say unintended consequences, but so, I started off with listing sort of the justice involved folks we've got up there, people with serious mental illness who are at risk of either at risk of institutionalization or they need some sort of step down services from residential care. Then, picking up on something Senator Bouchard said, really homeless people or people who don't have social networks. And then, though, as I look at that list, the problem with having that be the list is that kind of what Representative Olson said, is that in some ways you, I don't want to say incentivize people to get on the list, but if you draw the list there, then you've got people who are not quite in that category yet, and because they're not getting any service, they end up in the category, because of lack of prevention or the ability to reach those folks. I'm trying to find the sweet spot between that sort of thing and prevention, and then the budget problem. So one other thing that then I wrote down that and I'm not quite sure how we would make this happen, but one of the challenges I think in general in human services is that things tend to be very siloed. I mean, that's one of the things we're trying to overcome with the criminal justice reform and all, but you've got this service for the adolescents, you got something else over in the schools, you've got this other counselor, you've got, whatever housing thing, or, I mean, it's all broken out. And so the more we have to move for financial reasons to more of a safety net side and less of a broader access, the more we need at least some way of providing case management assistance as people start maybe having to get their services in the private sector, or there's a program through a church or something like that. You've got providers that, and I think one strength of the community mental health centers is that because of their experience with clientele, they tend, I think, to know at least what the community resources are for housing or diversion or prescription assistance or whatever. And as people, especially, even people who have insurance, so maybe they're going to a private counselor for their child, but they don't necessarily know how to access all these other services. So I think maybe at least as we have to, maybe move the dot a little to the right, if there is some way to use the case management resources of the community mental health centers to enable people who are maybe getting services elsewhere to tie together all the parts. I just feel like case management is so key, I think. You know, it's sort of very related to the continuum of care, but just people just, I mean, that's why I have people call me. I mean, who calls a legislator to find out how to get meds for their opioid addicted kid? I mean, that I'm not but people are at their wits' end and they don't know how to get services for people. And certainly there should be somebody other than a legislator who helps them with that. So that's mainly what I have to say.
Thank you, Representative Wilson. You all certainly have a lot of experience, with this issue. I can tell dealing with constituents, but sort of bring it back to a more high level and the population categories to be served. I just wanted to see, Representative Larson, I wanted to bring it back and give you a final say. Do you see any populations that are missing that you would like to see added before we move on to our next step in the exercise, or any other members for that matter? Are there any big populations that we're missing?
So, Jerry, I recall with our WAMSAT group that there were several comments there on the high needs substance abuse. Do we feel like we have that covered in here?
Yes, we'll add that. Thank you.
And then there was also a concern as we talk about this, as we reflect on state dollars, as the impact that would have on the SAMHSA funds and who the designations there. I don't know that that's really part of this discussion, but just a comment that just to let the committee know that in SAMHSA there's some designations there, and we're not throwing them aside, but we recognize that they're into there, like veterans and minority populations, as well as pregnant women and those sorts of things. So how about a comorbid needs? High needs. Okay.
Great.
Okay.
Okay, I think, let's see, did I miss anyone? Did everybody get a chance to share populations?
If I can just make one insertion on Representative Larson's comorbid health conditions, just to flesh that out. And I'm not sure about this, but it was mentioned to me earlier in the year, the challenges with people who are dual diagnosed with mental illness and developmental disability. That's not to say that there aren't private providers who are available to that. And of course, those people will typically at least have Medicaid. So they at least have a payer source, but, and that's not to say that any particular community mental health service would necessarily have expertise in that. But I just throw that out there because it was mentioned to me by some of the providers that this was a challenging group to find good services for.
Thank you, Representative Wilson, for that addition. With that, we'll go ahead and move on to the next step in the exercise, which is basically what we're going to do is look at all the populations that we have brainstormed, and we're going to try to cluster and group these together into sort of population buckets and give them titles. And so, and then of course, during the course of this exercise, if additional populations we forgot to mention come to your mind, you know, we can certainly add those as well. And so it looks like Franz started a sort of grouping things together initially as we started discussions, but are there any groups that really stick out that we could sort of title and group together in one population bucket? It looks like justice involved is sort of a natural one that has sort of emerged, which would involve Department of Corrections, Title 25, Title 7, just involved in institutional.
Does that include, oh, okay, there he's got it. I was going to ask if that includes the DFS kids.
So with that bucket, justice involved, and are there any other items that need to be included under there? We have Department of Corrections, Title 25, DFS. Okay.
Hey, Jerry, this is Stefan. Can I make one comment, please?
Yes, please.
So just for the group, because this has come up several times in our other exercises, just so you know, we understand there's plenty of overlap between these categories. This is really geared at, again, when we'll come back to kind of the role of the state conversation before introducing any financial or legal constraints, this kind of grouping, knowing that there's interaction between the different groups, kind of helps frame it from a policy perspective on what those, you know, kind of policy level population categories would be. Again, noting this is not clinical or kind of official definitions, but if you think of, you know, the kind of direction that the legislation from the facilities task force gave the two behavioral health safety net facilities, it, you know, coming up with those categories was very helpful for us in the executive branch to get a sense of what, you know, what problems we were aiming to solve. For example, it wasn't clinical or again something that came from you know, a medical handbook, but the legislature realizing at the end of the process, there's just some folks in behavioral health facilities that are hard to place, you know, externally in nursing homes, in the private sector, what have you. And that hard to place category actually became legislated to, that the executive branch could then execute, you know, what does that mean to be hard to place? How many facility rejections or nursing home discharges would have happened? So this is kind of the first stage in that process of understanding from your perspective as policymakers, what are some of the, again, how do we collapse some of these definitions into what if the system were moving more towards a prioritized definition of service for these state dollars in the community mental health system, what would those kind of policy categories be that the policymakers would be directing the state to make sure we design a system around them? So hopefully that's helpful as we start to, you know, bucketize these, for lack of a better term, but we totally understand. For example, right here, justice involved in institutional will certainly overlap in many cases with a, you know, acute psychiatric crisis client. But I think those do make sense, at least in our other exercises, as maybe distinct categories. Thank you, Jerry.
Yes, thank you, Stefan, for that context and for that description of this portion of the exercise.
So, Jerry, just to flesh out the justice involved, I am taking Department of Corrections to, in a way, be a generic term, because, you know, I mean, it would be a pity if somebody that the Hot Springs sheriff was well acquainted with for several years had to wait until they went to Rollins or something before, you know, I mean, obviously the local corrections systems, or even the federal. I mean, if a person is you know, in federal court and they've been drug running wherever, you know, I mean, so I'm taking DOC to be generic for any corrections operator.
Jerry?
Yes.
Building on what Representative Wilson said, that's a fantastic point, and there might be a better phrase, even the Department of Corrections generic justice involved, I think suits it best. But so what we don't have here is, let me see, I thought we had somewhere the people that were in danger of being sent back or sent to the poke. Where did that one end up? What happened to, okay, preventing recidivism. So you've got a whole category of people, they get arrested, they need to have the addiction severity index administered. They may or may not go to the local mental health center for that. They have not been incarcerated except over the weekend. They've not been adjudicated, they've not been sentenced. And they may be adjudicated and sentenced, they may serve time in a local county jail. So there's got to be a broader moniker than that, because that's where a lot of these people still fall through the cracks in the system. There's a waiting list for those folks to get seen. Sometimes we have, I've heard that there are county court justices that will send people to private providers rather than the community mental health center, which means you're paying twice for the same service. So I think Sue's admonition that we need to keep this much more broad than just DOC is a good one. Thanks, Representative Wilson. That was a good catch.
Yes, thank you, Chairman Kinski and Representative Wilson. And the justice involved in Department of Corrections has come up in our previous exercises as well. And with that intent that it was the more generic reference to corrections in general. And so with the issue of recidivism, would that fall under the, with preventive, and would that fall under the justice involved, or is that more of a high need substance abuse scenario with preventing recidivism?
Yes, both.
Okay.
They're in danger of backsliding because they've got drug and alcohol issues. What's the statistic? 99% of the substance abuse clients through the community mental health centers have they're justice involved. Or no, of the justice involved clients, 99% have a substance abuse problem. So it's one and the same. They're danger. So preventing incarceration or recidivism, I think, is a more accurate phrase, because if they're released on OR, it's typically on condition that they lead a law-abiding life, they stay out of bars, they don't drink, they don't use drugs, and they get counseling. And violation of that usually ends up putting them into the county jail or the prison.
Okay, thank you. So what about sort of moving to the right part of our screen here? What about the indigent, unemployed, underemployed? Let's, if we can, move toward discussion about how to categorize this group and what may fall under that.
And Jerry, this is Stefan for the committee. I would just mention, again, the first three buckets you see here are more kind of the way we think about it in the health department and our other programs is categorical, I think, to paraphrase some of Senator Kinski's language from the discussion. And now, just queuing up a question, moving to the financial side, or what you see in statute in our contracts in many cases is inability to pay. So just want some discussion from the group if that makes sense as a population, a priority population category, kind of in this blank slate before we introduce resource constraints. With the role of state dollars in the community mental health and substance abuse system, should they be geared towards those with an inability to pay, either with categorical overlap in some of these buckets or standing alone?
So this is
I'm not
again.
sure I understand the question. Ask the question again.
Sure, Senator Kinski. So, again, thinking just in the context of the role of the state with these state dollars for community mental health and substance abuse services that the Department of Health manages, would a category of inability to pay or indigence, so uninsured, not able to finance or pay for mental health and substance abuse services, does that make sense as a bucket here, as a standalone bucket, as kind of an eligibility criteria or category for the use of those state dollars, or does it need to overlap with the other categorical elements that you see on the left-hand side of your screen?
So this is Sue, and my thinking on this is that I think that this needs to be sort of a two-part assessment. If you think of a flow chart, a person who is unemployed, but let's say they just want marriage counseling, and I don't say just, because marriage is important and marriage counseling is important, but I think that given, and maybe we don't want to get into resource constraints just yet, but I do think that if a person comes in and they're just not able to pay for marriage counseling, let's say, that maybe the sort of the case management aspect might then say, okay, here are some community resources, whether people that do pro bono or nonprofits or churches or something, but I don't feel that the state at this time is going to be able to provide all services to everybody who can't pay for the services that they would want. I think that this is an area where we need to, have the sort of a flow chart thing and direct people to somewhere else. That's what I think.
And Representative Wilson, this is Stefan, and sorry to jump in, Jerry, but it piqued my interest. In terms of that ability to pay, Representative Wilson, when we talk about folks who are uninsured, as you know, with many years on the Labor Committee, that often is measured by the federal poverty level. So to bring in that conversation from earlier about access to other resources, whether they're state financed or the insurance market, the private market, federal funds, what have you, would that be, not to be overly suggestive, Chairman Wilson, but would that be kind of how you're thinking of uninsured in a traditional sense, would be folks who in Wyoming would be under the federal poverty level and thus kind of in that coverage gap, not eligible for Medicaid, and maybe not qualifying for federally subsidized health insurance? Or was it kind of deeper than that?
I don't know that I really pinned it down as far as a specific level. And to Representative Barlow's point earlier, communities really vary, and people's ability to access services vary, and what's available in the community varies. So I'm not saying that we can't say you have to be under 200% of the federal poverty level or something like that, but I think that sometimes there's some gray area in that. I mean, a person who gets laid off in July and loses their insurance, if they were making $80,000 a year before, of course they may have savings, but I mean, I'm not sure that I can really pin down a mathematical point right now, but.
Okay, thank you. And again, these are just initial discussions, so plenty of time to, discuss details of, as we move forward at a future date.
Jerry? This Lloyd.
Oh, yes, please.
So I would assume that we would move that serious and persistent mental illness up into the inability to pay.
Likewise, would adolescents in need of MHSA services, is that going to end up going over on the left? Or are we talking about that they just generically have a need, or are we talking about they're caught up in juvenile justice and protective services and Department of Family Services? Isn't that how they get to us typically? That they're caught up into the system in some way? Shouldn't that adolescence in need of MHSA be over on the left? I'm asking.
Thank you.
I'm asking the group.
Personally, I'll just say not necessarily, because there are an awful lot of people, and I'm speaking from, some personal knowledge of some people I know, between the ages of say 12 and 16, who their families, their schools, their churches are wrestling with how to help this youth and prevent them from ending up in DFS and in juvenile court. And through even if people have insurance, but the inability to pull together all the community resources because people are kind of out there on their own trying to help their kid, and there's these silos. I mean, I think we want to, if we can catch these kids before they get there, that would be far better for everybody. And that kind of fits a bit into that DFS family first process, I think. But so I'm not, maybe I'm bringing in too much overlap.
Well, maybe it needs to be on both sides of the ledger then. I think that, when there's a child and there's allegations in the family of abuse, one of the parents has a drug issue, the child they may not be to Chin's level yet, or maybe they are Chins, and we're trying to avoid putting them up into the girls' school or sending them off to some other PRTF something. I think that this adolescents in need of MHS services, because they're either caught up in the system or we want to avoid them getting further into the system, is more akin to what we've got on the left. So but I also see that another category that Sue's talking about where they haven't gotten to that point and they need some resource or case management. So I think this adolescents in need of MHSA has to be over here on this left side of the ledger that has these people that are all kind of getting ground up or in danger of being involved with the justice system, broadly conceived.
Thank you. Would it warrant perhaps adolescents being their own category, knowing that there will be overlap perhaps with the justice involved category and the inability to pay category?
Well, could be, and I hate to say this because we haven't gotten to the resource question yet, but wouldn't you prioritize children that their parents are looking for help differently than a child who actively is in a Chin's situation that needs MHSA community-based services? I mean, at some point we're going to have to decide where the cut line is here in terms of what we can afford to fund. That's why I was advocating it for a separate locale on the left-hand side as well as a home on the right. But whatever the group thinks, or whatever you think, however you want to do it, it's your exercise.
Thank you. Chairman Larson?
So kind of following that discussion, in what I see with adolescents is, and there's this crossover particularly as you get into the 16, 17, 18, where you start to see bipolar stuff start to exhibit, and in depression becomes, and these adolescents or young adults are struggling to try and figure out what's going on. And so I agree that if we can identify that and provide the services, but are those services provided in, and I just want to make sure that I'm understanding this exercise right, because how many of them would be receiving services within the school system or through private, and does this, and we're not taking into any consideration the pay source. I think so help me with that a little bit, Jerry, right now, because I agree with Senator Kinski. This is, if we can get it identified before they get to correctional problem, but I'm
Yes.
a little bit lost.
Thank you. To address that, Franz put down a possible bucket of preventative, or those maybe in need of preventative or case management. And if we had adolescents under that category, as well as adolescents that are, you know, just as involved with DFS or with the court system, perhaps that's how we can get them on, capture adolescents on both ends of the spectrum, pre-involvement with a state institution, and or those at risk of entering into a state institution. Would that category capture sort of the concerns?
Let's give it a try and see.
Okay.
And Jerry and Representative Larson, if it's okay, I was just going to open up the discussion on SPMI. I just personally think this category is a little bit different from the other ones in here, because these folks might not necessarily have serious mental health issues. They just can't pay is kind of the definition of the bucket. And I wonder if this might fit better with some of like for example, the high need substance abuse, you know, as sort of being more of a chronic, you know, condition, you know, where folks just kind of have to be maintained over time, versus, you know, not just having the inability to pay. But wanted to throw that for discussion.
So I guess, Jerry, if I may go in there, and I appreciate that, but I guess as I look at state resources, if this serious and persistent mental illness individual is on an insurance policy, then I don't think it would fit into what the state would provide services for. I think that these are the people that are out there in our community, somewhat indigent, that don't have a means to pay and don't have insurance. So help me there, if you would, Franz.
So I can add like without means to pay here if you want to, unless there's a discussion about the people that do have, you know, for example, to Senator Kinski's point about, you know, there may be people on disability on Medicaid that have SPMI that maybe not be adequately served because of the, you know, as Senator Kinski mentioned, the Qualis utilization management limits. So I don't know if that would be a separate category of people with, you know, chronic conditions that have a pay source, whether it's Medicare or Medicaid, and the state is still interested in trying to wrap additional services around them or not.
Well, I guess I was thinking, Stefan, I guess, Stefan, what I was thinking was more on those people that have these conditions that don't have the means to pay. I don't argue that the other exists as well, but that's the population I was referring to.
Okay, Representative Larson, is it okay if I just added without means to pay then to clarify that? Okay.
By the same token, should high need substance abuse be up there right after serious persistent mental illness?
So this is where my discussion about sort of the case management and flow chart fits in a sense, in that, you know, if people, so we've got sort of an intake case management assessment thing. People come in and maybe they've got serious and persistent mental illness, but they can pay, and there's a community provider, you know, you can route them there. It's same with, you know, maybe, I mean, I don't know how many private providers of substance abuse treatment there are, but maybe there's another resource and you might be able to put them there. Maybe there's an unemployed person who wants marriage counsel. I mean, so in some ways, the case management aspect and the inability to pay aspect kind of work hand in hand, in that if there are resources for these people, then they can be sent somewhere else, plausibly, whether it's serious mental illness or marriage counseling. And anyway.
Thank you. This is turning into a really great discussion. I wanted to raise attention to some of our categories that are kind of outlying the comorbid health conditions and dual diagnosis, developmental disability, and mental health. Any discussions on those being sort of their own categories or falling into one of our existing categories, sort of on the opposite end of the spectrum of acute psychiatric, we have sort of long-term, mental health, substance abuse issues that may need to be addressed there.
So Jerry, if I may, if we look like at comorbid health conditions and dual diagnosis, as we went through the state health facility discussion, and we said, if there are people that fit into these categories that the long-term care facilities are not equipped to deal with, the safety net there then would be what we're doing with the expansion at the Life Resource Center, with the intent that they would then go back out into the community once they're stabilized or have, anyway, they would have an exit plan. And so as we look at the dual diagnosis and the comorbid, is in this situation, are we looking at the community mental health providers as being the safety net, or leaving that on the state facilities as a safety net? If we're leaving it on the state facilities as a safety net, then how are we looking at these two conditions being served by the community mental health providers? Is that a fair question?
And Representative Larson, this is Stefan, to jump in there. I think it's a great question. With the DD population that might have dual diagnosis with mental health, I think that between the new missions of the two state facilities, as well as our already established Medicaid waiver programs, home and community-based service programs, do in part, if not a substantial part, capture a lot of that population. So your question is a good one. When we bring this exercise back to, is there a role for the state funds in the community mental health and substance abuse system for a population like that? I think you find people in the legislature with much more responsibility than us. You're thinking kind of statewide, right? Because it's difficult not to. You think of mental health and substance abuse services as across Department of Health, Corrections, Department of Family Services, other systems, which is totally appropriate. But in this particular exercise, I would answer the question with another question, respectfully, sir, that is there some role, some safety net role for the community mental health and substance abuse centers with state funding to target a population like comorbidity with or a dual diagnosis between DD and mental health? And I'm not suggesting one answer over another, but I think it's difficult to not think of that population within some of these buckets that have already been developed here. For example, to your point, Representative Larson, about this two state facilities, that population that the facilities task force and legislature determined would be served on an acute basis at the state hospital and then discharged to the Life Resource Center for further stabilization and ultimate discharge back to community providers or community supports. That, to me, in the DD plus mental health world, would fit into a pre or post institutional category. So one of these, either justice involved or kind of acute phases. So I think it could, again, just my personal perspective, going with participating in both this project and the facilities project, that category seems to float between these ones that you all have already, somewhat determined to be their own.
So Jerry, if I may, I agree with that, but the role in our community mental health system for these is what? And I would see it, if we already have services or through behavioral health and our community providers to address these issues? Is it the role then of the community mental health providers just to assess and make referrals? What would be their roles? Because we don't want to, I don't see, I think we need to be careful that we're not duplicating services.
Thank you, Chairman Larson. That's a great question on what to do with this group that's, already, there's a safety net for them in our state facilities. Is there thoughts on the group of what the role of the community providers are with dual diagnosed and comorbid health, those with comorbid health conditions? Is there a role for our community providers with these groups?
I don't have I'm going to tangentially take us slightly away from that because I've been meaning to mention this for a while, but I think in our current system, in my mind, we're missing a completely third category. It's not just justice involved in inability to pay, but there's an access, and maybe that's more of a resource question, but there's a whole category of access. And if we're talking about the system that we have, and where we have our community health providers, okay. But if we're talking about the future of our system and maintaining it, access is a category for me. And then of course there's some type of function that narrows down who receives services. But in a rural state that we have, there are communities where it may not make profitability sense for an institution to set up shop there. And that's why there isn't an institution there. And so having one of the state's functions, I think, should be to provide access in those rural areas where the services don't otherwise make economical sense from the private sector. And so you may not have a justice involved scenario. You may not even have your complete economic hardship. You just simply don't have the resources because of the rural community. And those tend to really compound because when you have geographic isolation, mental health issues, et cetera, begin to grow, especially it crosses into the other categories of vulnerable adults and, adolescents where they are in geographic isolation, the mental health issues may compound. But I would say general access is also a duty of the state.
Thank you. That's a great point. And Franz added that as an additional category. Are there any specific populations that you would want to add under this, or is it just rural populations or anything else you want to add?
Yeah, I think it's just rural populations because I would say it filters through these inability to pay and preventative case management and even the justice involved systems. It's going to filter through them for the most part, where it's going to double touch those people. But I guess I would envision potentially there's scenarios where someone's not unemployed and they have insurance, but they need a facility to go to, right? So, or they need providers. And they may not be in their community. And I would say that's a function still of our system is to help establish those providers in those communities where even if they have insurance or they are employed, they still need access to it. And that becomes a whole different universe, of course, than what we're talking about because the cost to the state is much different. But I think we end up double dipping those because we put our resources obviously towards the more high risk categories. But I think rural populations is fine.
Thank you. Thank you for that feedback.
But is that not the structure of our community mental health system currently, that general access is available, and then there is a structure to reimburse through the program those some of these difficult populations? So nobody So I think the intent of the currently is to allow for some general access to services. Even if you have the means to pay or insurance to pay, they'll take that. Even if you're on Medicaid, that can be that can cover the cost there. You're just looking for the resources. And I don't think we're saying to do away with that at all. And I think that we all recognize the importance of having that, particularly in our more rural areas of the state.
Yeah, Representative Larson, good point. That's why I raise it, is that I noted in the beginning that we're talking about the future of our system. I just want to make sure that it's not overlooked, that it's still part of the vision.
Okay, thank you. And trying to wrap up this section of the exercise, we still have those dual diagnosis, comorbid health conditions, excuse me, that there may need to be further, I guess, policy discussions on what the role of a community mental health center would be with those groups. Any concerns or comments on the buckets that we already have and sort of how things were grouped together before moving on to our next exercise?
I would like to chime in.
Yes, please.
So, watching the conversation on and addictions have popped up several times here. And I don't know if this is a bucket, but look, we mention of how sometimes we try to keep people out of a system, or we're seeing them recurringly coming into the system. And what I see is we need to really revisit the whole thing with addictions, because what we see are states that have become tougher. And I say tougher in the fact that people do become arrested and incarcerated. And when you look at some of this population that has been addicted for over 25 years, and they finally come to grips with what happened in their whole life, they said that the system finally saved them. And I want to think about all the cost that has happened in a 25-year plus cycle of incarceration and letting them out and in and out and getting in trouble and trying to go through addiction services on the outside. What kind of finally happened is the system got it right, said, you can't do this. We've got a couple of options for you, and you have to complete these things. Sometimes they use drug treatments. They use pharmaceuticals to actually treat people who have been habitual for many years, and they have to take those drugs, and it counterbalances how their system reacts with that desire to be addicted, to take drugs. Anyway, to narrow it down, we have to revisit how we're treating those people when they first get in the system. And there's this tendency where we want to go, well, let's just make this easier, and let's make it an outpatient thing. Let's try to get them through this crisis. Come to find out, all we're doing is harming them, because they're just stuck in a cycle they can't get out of until we say, hey, enough's enough. We've got to stop this now. This is what, there's punishment that's in place for correction. That's what corrections does. That's what the objective is for the Department of Corrections. And so we're missing that. And there are states that have gotten tougher, and they put these systems in place. And when people get out of the prison system, they actually go to an outpatient type system where they have to go get their drugs and I'm saying drugs that actually treat the addiction part in the chemistry of that. So and if that's the way they're treating it, it depends on what type of drug they're addicted to. There's other cases where they'll go to an outpatient when they get out, but and they may use other methods of treatment. But the bottom line is, if we just keep thinking we're going to bounce them around for 20 plus years, look at the cost that's involved to all that. So like I'm saying, I don't know if it's the right for a bucket, but it's certainly, we have to revisit how this is working because it's not working. So that's my 2 cents.
Thank you for that comment. Any response from the group on addiction? Whether that should be its own category? Do you feel like it's those with addiction are adequately captured in sort of our existing categories?
Jerry, if I could suggest real quick, this is Franz, maybe we could subdivide this bucket into, just for the purpose of this discussion, kind of maybe break out sort of the higher needs folks without ability to pay from the lower needs, I guess, and not to, I'm sure people that maybe are unemployed or uninsured have needs, but to Senator Bouchard's point, and to, I think there is sort of a little bit of a divide here between sort of an inability to pay and inability to pay like high needs, category, and kind of thinking of them differently, treating them differently from the sort of the broader inability to pay / uninsured population, if that's okay with the group, something like this. But again, this is an exercise for you all, so if you disagree, we can certainly change it back.
Okay, any concerns with sort of subdividing that group? Okay. All right, well, in the interest of time, I think that we will just put our last 2 categories sort of in a parking lot area. This was certainly a great discussion. Thank you all for your comments and sharing your thoughts and experiences. This certainly isn't the end all and be all, right? You all will have time to refine and go through these at a future date in more detail and make revisions. This was simply an exercise to start, to see where we're at with these populations that the state would be serving. So moving on, I guess Chairman Larson, did you have any thoughts on this before we move on to the next exercise? Okay. All right, so this is, we've gone through and identified populations to be served, sort of attempted to categorically group them together. This was just sort of throw everything at the wall exercise. Who are the people that we would want to serve? And now let's introduce some constraints. And so, in an ideal world, we would have enough resource to serve all of them. But now that we are introducing funding constraints, how would we go about sort of prioritizing each of these categories? And so I want you to take a moment and think about how perhaps you would rank these with a percentage, right? If we had X amount of dollars, we had what percentage of our state funding would go towards each of these categories?
So, Harry?
Yes, please.
And I'm not so much worried about, let's not think about it so much in dollars, but let's just think about it in percentage of priority. Is that fair? Because we've not brought funding into this, but just if you had to place an emphasis on priorities, how would that, and maybe that messes up your whole thing. If I'm wrong, then carry on it as well. And then could we also just ask Franz to send us out his bucket list real quick so that we can refer to it like he's trying to, because we can't remember all the buckets and how he has them.
Yes, I think percentages would be, to your first point, percentages would be a great way to consider this, percentages of priorities. And then Franz, do you want to flip back to the previous slide, please? So these are, why don't you take a look at these and think about how you'd prioritize them, take a minute or two, and then we can share and have a discussion on thoughts moving forward. I also want to emphasize that this is, again, we're not holding anyone's feet to the fire here. So this is just more of a thought exercise to see where, as a group, we may have consensus about the priorities of populations. So no fears about that. You know, the way one thing's allocated here is, you know, how it will end up in legislation or anything, but just more of an exercise to see if we can come to consensus. Representative Barlow, did you have a comment?
Thank you. So my question is, in considering how we rank this, should we make any assumption whether some of these folks, I'm looking at the justice involved first box, justice involved, they have a choice whether to use community mental health or private providers with the same access, or do we have to make an assumption that they would not have the same access to provide private providers as they would the community mental health? Thank you.
Thank you for that question. Stefan, do you have any thoughts on the underlying assumption with the justice involved and whether they'd have access to, you know, private providers, or what sort of assumptions we're making there?
Yeah, thank you, Jerry. This is Stefan and Representative Barlow. It's a great question. And I think for the purposes of the exercise, again, I want to funnel this as much as we can back to the role of the community mental health and substance abuse system. So I think for the justice involved populations, it would be kind of an assumption that you know, the court system or the legal system would be funneling, you know, towards the community, the state funded community providers, because otherwise I think as you kind of alluded to, sir, it just gets too big. It's the same as, you know, with, you know, Title 25 directed outpatient commitment, where the court does have the option, and clients and patients often have an option to use a private provider. But I think we assume for this exercise that we're talking about that safety net role when maybe there isn't another option in the market.
All right. Thank you, Stefan, for that clarification. And if we're ready, Franz, can you click to the next slide? And we will, I guess, open it up for discussion on on prioritization of these categories that were defined. Oh, there it is. Thank you.
Sorry, Jerry, I think I clicked leave the meeting when I meant share screen.
it'd be helpful if I could see the prior screen too. Could Franz email that slide to me? Maybe you can show it 2 notes at once. So.
Are we able to view both the slides at once?
I'm working on something.
There you go. That helps.
Right. Hopefully it's not too small and everyone can still see. Also, the titles of the populations are listed on the left side of Franz's chart there. But if you want to see the detailed, it's available on the right side of the screen. Okay, let's start with Representative Wilson. Would you be willing to sort of start and share with us the high and low, sort of how your list ended up being ranked?
Sure, I was hoping I'd end up being last there, but I see you pulled a teacher trick on me and started on the other end of the alphabet. So, you know, as I did this, I really realized that I wish that I could like make them green and yellow instead or something, because I'm really, you know, hopefully we're not visualizing a community mental health center that has one poor overworked staffer and that's all they are, and they have to send people out into the road. So I'm numbering them, but I'm not wildly nuts about my numbers. So I actually put acute psychiatric 1. And then the non-state justice 2. My thinking on that is that once they're in a state institution, I mean, if they're in the institution, then you don't really need the community mental health center. So 3 is the state institution people, I guess. I don't know, I was kind of not, anyway, just put the top justice 1, number 3. But that, to my mind, that 1, 2, 3 is a kind of a big wad there. And then 4 is inability to pay high needs. And 5, the case management. And then really, I think inability to pay and general access are both 6. So I don't know if you want to put them both 6 or 6 and 7. I don't care how you do that, really. I felt like that was sort of a category. If you're for the purposes of your exercise, you need a number, I guess you could put general access as 7, I guess.
Thank you. I appreciate you being willing to go first. And I recognize that it is really difficult to rank these, especially after our discussion talking about the importance of each of these categories and how they, you know, how nuanced and multifaceted mental health and substance abuse is. So appreciate that. Again, just a way to gauge general consensus, see generally where everyone is. These categories wouldn't be up here unless, you know, you all agreed that they were important in some way. So want to make sure that, like I said, just an exercise to find consensus. Would there be anybody else?
Jerry?
Who's that? Yes, Chairman.
So my question is, do you want us to rank them in what we think is priority? Because that's a little difficult for me, because I see some, if I'm looking at resources, I may look at some of them as equals. So help me understand how is this how you want to, because I'll go back and do that. I just want to make sure I'm understanding the instruction correctly.
Oh, yes, thank you. Well, the instruction was for percentages, right? So then we would be able to sort of rank two categories the same if necessary, but
So,
yeah.
so let me make a stab at that, and then if Sue wants to come back and look at that a little later on, but and if I'm doing it wrong, please correct me. But I thought I heard that a little bit differently. So the way I would do that on that first justice involved, I put 30% of that's where I'm at is 30%. Then the next one is the justice involved non-state would be 10%. The acute psychiatric at 15%. Inability to pay is really a 50% of our effort, or 15% of our effort.
I'm sorry, sir, you said 15% for both of these?
Yep, 15%. And then on inability to pay, 15%. High needs. So you'll have three of those in a row that are 15%. And then the last two at 5%. That's if I remember I'm using Lander math. And so if that doesn't make 100%, I'll have to go back and correct it.
Thank you, Representative Larson. Representative Wilson, would doing percentages make the exercise a bit easier for you?
Okay, I've worked my percentages now.
Okay, great. Thank
Okay,
you.
I'll just start at the top. I put 25, 25, 25, 10. Oh, wait, let's see. I don't have, there's an extra thing here I don't seem to have on my, there's 7. I only had 6.
You got 15 left.
Oh, yeah. Okay, 10 there. Wait a sec, 75, 85, 95. Oh, let me back up. Okay, inability to pay, but go back up to inability to pay. And I'll put that at 3. And case management at 10. And general access at 2. Does that add up? 75, 85, 95. Okay, all right. There we go.
Jerry, I'll stick with the original exercise. I was on another subcommittee with Representative Olson and I didn't color within the lines, and I'll never do it again, Jared, I promise. I'll just stick to the methodology given us. Okay, 1 would be acute psychiatric.
Oh, hey now, they made me change.
Yeah, I like the ordinal ranking system. I think it forces us to make choices, which is what we've got to do. 1 is acute psychiatric. 2 is justice involved state institutions. 3 is justice involved non-state institutional. Let me see what inability to pay high needs would be 4. Case management would be 5. Inability to pay would be 6. General access would be 7. I think that's pretty much what Sue did the first time.
Thank you. Again, this is just like I said, because it's an exercise just to gauge consensus. I think whether you feel more comfortable with number rankings or percentage, whatever is easier for you to conceptualize, I feel like either way, at the end of this exercise, we'll be able to gain a sense of consensus of where the committee stands. So let's see, anybody ready to go next? I'm sorry, Senator Guru, thank you.
Yeah. Well, I got to stick with my senator on Senate way of doing this. So I'll stick with Senator Kinski's model, and I would actually go exactly the same as his, but I'd swap acute psychiatric and justice involved. Oh, 1. Yeah, there you go. There you go. And then just got it.
Thank you. Senator Schuler.
Thank you. I guess I'll go. I had percentages and numbers, so I'll stick with the senators and go with numbers. So I had justice involved number 1 from state institutions, justice involved non-state institutions number 2, acute psychiatric number 3, inability to pay 4, preventative 5, inability to pay high need 6, general access 7.
Thank you. And since you did have percentages, would you be willing to share those so we can throw those in as well?
Sure, I had 25%, and then 20 for number 2. I'm gonna have to check my math now too. Acute psychiatric 15. Inability to pay, I think I had 10. 10 for preventative. General access, oh, whoops. General access, I think I had 5. What am I missing? Inability to pay high needs. I think I had 10. Does that add up? Let me check again. Let's see, 45, 60, 70, 80, 90, and it lands up 95. Let's go with inability to pay 15. High needs. Oh yeah, oh, inability to pay, perfect. That's perfect.
Okay, thank you. And moving forward, for the purpose of the exercise, I think that percentages would be preferable. It gives us a little bit more data or insight on what the group's thinking. So would encourage the remaining members to consider percentages if possible. So let's see. It looks like we have Senator Bouchard, or I'm sorry, Representative Olson, is your hand up?
Yep, yes, I'm ready.
Okay.
I mean, I've got numbers, percentages, fractions down to, no, I'm just kidding. I'm conflicted. I don't know what system to use. Okay, 25. 25. 15. 10. 15. 5. And 5.
Thank you. And looks like Representative Barlow, do you have, are you ready to share with the group?
Sure. So can I use an alpha coding ABC? Would that mess anybody up?
No, you
Let's go with
cannot.
20. I'll start at the top. 15, 15, 20, 5, 10, 10, and 5, and I got to make sure it adds. I think I'm still short 10, right? 25, 25. I need 20 more. So add yeah, 5 to high needs. So 15 on high needs and 10. How much do I need? 30, 50. Add 15 to add 5 to case management or preventive case management. I tried to find someone I could duplicate, but nobody was near me, so. I should be.
Okay. Thank you, Representative Barlow. And then finally, Senator Bouchard.
Yeah, I'm really torn here because I see the justice involved, and unless we were to undo laws, I mean, that stuff's going to happen whether or not we decide to spend money on it. It's gonna accrue costs. So my percentages are going to be high on those, but at the same time, I got to balance the needs with everything else. So I mean, mine's going to be a lot more simplistic, but I'll do a number ranking first. So the number ranking would go going down 1, 2, 3, 5, 4, 6, and 7. And then what I would do is I would take the top 3 lines, and those would all be 20%. And then I just want to be fair to everybody. I would do the rest, the remainder of 10%. I mean, we have all of those issues there. I mean, preventative case management. If we're not doing that, we fail. If we, I mean, we're going to have some general access issues that are going to fall in the rural areas that we need to take care of. Inability to pay high needs. Obviously, we got a problem there. Inability to pay. The people they're having problems. We're going to get stuck there with that anyway. I mean, that's what we're dealing with. We're dealing with the people that can't take care of these things themselves. So, like I said, mine looks a lot more simplistic in nature, but I think I'm being pragmatic and seeing what the problems are, and we're going to have to address them anyway.
Gary,
Yes, Chairman Larson.
can you coax another 10% out of Representative Barlow?
Does that not add up to?
All right.
Yeah,
Add,
he's with
add
10%.
five. Add 5% to the justice involved, and 5% to the prevention case management.
Again, I use Lander math, so somebody double check me.
All right. Senator Guru, did you have a comment?
Oh, I've got some percentages for you just to make sure get everybody right here.
Thank you.
25% on, yeah, there you go. And 15, 20, 10, 15, 5, and 5. I think I got that. Now, yeah, I'll have to have Mr. Chairman check my Jackson math.
All right, thank you. I know that's a difficult exercise. And I think it's an important exercise though, to see where everyone stands. Taking a step back and looking at this chart, any thoughts or discussion you want to have about this, any changes or before we move on?
Oh, excuse me, Jerry, this is Stefan. Very briefly, for the committee, I'll just mention that we're more than happy, following this meeting to clean these slides up, format them a little bit, and kind of show what the feedback was. We totally understand going through this exercise, without exactly knowing what you would be getting into, that there's likely going to be some more, rumination and thought about what this all means. But I think it's helpful again for us. And I think for the process to quantify as much as we can with what the committee's initial feedback was as we prepare for what this subcommittee and other legislative bodies might do with this topic. So again, color coding some of this stuff to see where the priority of the prioritization, if I can make it sound complicated, how that would shake out. But as Jerry mentioned, happy to take additional feedback now before we wrap up.
Jerry,
So Jerry, since everybody else did a percentage, I'd better do it.
Thank you.
Do 25% each on my first 4 choices. Everything else would be 0.
Jerry, see if you can milk another 5% out of our Jackson guy.
Senator Guru, looks like you have another 5% to allocate.
So Surprising that a Democrat would do that, wouldn't you? Yeah, 25% to acute psychiatric.
Thank you. Thank you everyone so much for your feedback and your discussion. As Stefan mentioned, that we will take your feedback and the information and notes that we have, clean this up and return it to this committee as a deliverable and as a tool to help you moving forward with determining policy decisions now about the role of the state, populations to be served, how we might consider those populations once restraints are presented. Unless anybody has any final comments about or discussion items, I would like to turn the time over to Representative Larson to sort of close up and discuss next steps.
Thank you, committee, and thank you, Jerry. Job well done. We're not herding cats here, I realize, and we appreciate the work you've done. And so, committee, I think as we look at this, and we've identified how our numbers come out, I would like to go back and ask a question to Franz and ask him if he's seen these numbers and these buckets significantly different from what they done in the Department of Health or what they done with WAMSAC. And then I'd like to, Mr. Co-Chairman, go to some public comment and then maybe come back with some recommendations. So Franz.
Yes, sir, Mr. Chairman. I'll just pull that up just to go through what our discussion with WAMSAC looked like. So this was initially, it was a very similar exercise with me trying to, put things on a whiteboard. We started off with this sort of brainstorm of all these different populations. You can see it ranges from pretty complex, I think this is the word of the day, psychopharmacologically complicated, but also, a lot of the similar ones like indigent, inability to pay, a lot of the justice involved. I think a lot of similar focus. There, of course, were, some, for example, some of the SAMHSA, the federal designations, for example, of IV drug users, pregnant IV drug users, women and children, I think were included on here. So this is sort of the brainstorm of all the different, that first slide. And then we sort of went to bucketizing them with WAMSAC. I think this was successful to some degree. You can see it's similar in many ways. We have the sort of indigent inability to pay bucket. We have the sort of institutional transition bucket, although this committee sort of divided that a little bit into sort of state institutions versus more local correctional processes, judicial processes. DFS and high needs kids was an individual bucket here. And then we also had a high needs substance abuse bucket that was broken out. And then I think we kind of stopped the exercise before we were able to finish bucketizing the rest of these folks. But these were sort of the main buckets that came out of it. And the discussion sort of shifted to role of the state. And Chairman Larson, this is a little bit different from the exercise that we just did with this committee. I'm happy to go through the slide, but it's not, there's no comparison, I guess, that we did. And this was kind of more brainstorming, what is the role of the state with respect to, from the provider perspective, what should the state be doing? What shouldn't the state be doing? And there was discussion about sort of this balancing between the contract language, how much really should the state be micromanaging the contracts versus getting out of the business of the rest of the business, because the contracts are not the entire business of the mental health centers. Looking at flexibility and state policy, really trying to align between agencies, because there are a lot of silos, as was mentioned in this discussion, and a lot of interaction between budgets. So how do you really braid and coordinate those payment sources? I think we really concentrated in this discussion mostly on the state general funds going to the mental health centers, but there's also Medicaid funds on both the PRTF side, for example, other funding sources that are available, SAMHSA grants, federal grants. And so this was sort of, again, a brainstorm on really what is the role of the state. I think this sort of focus on the safety net was also brought up. So, really, what is the role of the state contract specifically, and how does that interact with the rest of the business that they do? Was kind of the focus of this slide. Do you have any other questions, Chairman Larson or Co-Chairman Kinski?
Members of the committee, any questions for Franz in what we've got here? I can't see all of you, so just let me know if you see anybody there, Dave, that's raising their hand. So I think let's go staff. Elizabeth, do we have anybody that's wanting to make public comment on this?
Lloyd?
Yes.
Lloyd,
thank you.
You think we could take about a 9-minute break until 11?
I think that is probably the suggestion of the day. We'll take a how many minutes did you say? I want to make sure that I get this right.
Well, according to my watch, it's 10 till, so a 10-minute break.
10-minute break, and then we'll come back, be ready for public comment if we could, Elizabeth, please.
Will do, sir.
Thank you.
Chairman Larson, I see that you are back. The only individual that we have currently for public testimony is Ms. Somerville.
And Mr. Chairman, or Mr. Chairman and Mr. Co-Chairman, I just wanted to say I apologize. I didn't realize till I got up to get a cup of coffee that I didn't have my suit on. And I apologize for not wearing a coat, being properly attired. So, sorry.
Well,
It's okay with me, but Lloyd's a strict disciplinarian.
you know, that's like Mrs. Larson always looks at people's shoes. I never even noticed she didn't have one on, Mike. So sorry. Thank you. Thank you. Yeah. So I think every committee, we're back and we're ready for comment. I think we have one public comment, Ms. Somerville, who is the with our WAMSAT group. If you'd like to come on, introduce yourself and provide some comments, and then we'll ask questions.
Thank you, Mr. Chairman. Andy Somerville, representing WAMSAC and all your community mental health centers. So my comments are pretty brief. I want to thank you guys for going through the exercise. As you guys know, we completed that in a meeting with DOH, and surprisingly, as was stated, the results look remarkably similar to who we think is important in the state to serve. So I think that gives us kind of just confirmation that we're all working on the same page. I did want to make one comment about the conversation with general access. I know that was ranked pretty low on the sheet as you guys went through the exercise, but I just want to put a thought out there to think on further. It's really hard sometimes to know what bucket people fall into until we get them in the door. So one of the things that we've been discussing is, does general access mean that at least everybody's entitled to an assessment? So we get them in the door and figure out what their needs are, and then maybe refer them out to other resources. So I just want to put that out there for discussion and further discussion in the future. And then, Mr. Chairman, if it's okay with you, I'd like permission to share my screen real briefly to just show you guys a definition of what we've worked off in the past. I didn't want to give it to you guys prior to color your discussion, but I thought I'd share it now if that's acceptable.
Sure.
Thank you, Mr. Chairman.
And Andy, as you provide that definition, help us understand the origin of that, if that was a legislative or committee, or where that comes from.
Absolutely. Thank you, Mr. Chairman. So as you can see on your screen here, this is what we would consider, this is the definition of services that are provided by community mental health centers in Wyoming. This came from the Department of Health and used to be agency language that was included in all of the community mental health center contracts. That language is no longer included, and I apologize to the committee. I have no idea if that was just a paperwork reduction or if there was a change in policy. I've been unable to determine that. But this is what used to be in there. And I just wanted to highlight a lot of the things that we talked about or that you guys have discussed this morning: case management, clinical assessments, early intervention, medication management, therapy services, services for children and adolescents with SED. Again, just a lot of the things that have already been discussed. And what I think is important about this definition is to kind of understand how the community mental health system was built up in Wyoming. And for the last 50 years, 60 years or so, this is pretty much the outline of how they operate. So all of your centers provide case management. They provide what I would call wraparound services, just again to highlight the difference between maybe going to a private provider versus coming to a community mental health center. Very central to their mission is providing and connecting other services for these clients. And that's both for clients on the state contract as well as clients that come in that maybe have a Medicaid pay or a Medicare pay or are insurance paid, all of those things. So I just wanted to highlight that. I did forward this definition to Ms. Martineau and asked her to send it on to you guys. And I'd be happy to have any further discussion, but just to provide a little context onto the services that they provide now, and kind of how that's based. So with that, I don't have any further comments, Mr. Chairman. I'd be happy to stand for questions.
Questions for Ms. Somerville? I can't see all of you, so maybe.
Chairman, Eric Barlow.
Yeah. Thank you, Eric.
Thank you, Mr. Chairman. Ms. Somerville, thanks for the reminder of what has been a part of your mission, or understood in your mission for some time. My question is, of these, if this were still in place and the state was the payer, and I know there'll be a range, but if there's an average or a range that you could give of the community mental health centers that are in existence today, what percentage of the service that they're providing are paid for by the state and fit under these under this broad charge? Thank you.
Thank you, Mr. Chairman. Representative Barlow, I think there would be a range. Some of our centers, the state contract is 35% of their budget. Some of our centers, and this would be the smaller and medium-sized centers, it can be as high as 65 to 70% are state contract paid clients that fit within these range of services. I would say that the majority, more than probably 80% are receiving a variety of these services across the spectrum: state contract, Medicaid, and private insurance clients that come into the community mental health centers. It's pretty rare for somebody to just come in for counseling or therapy services. At some point, they're usually connected with other services, and we certainly screen for those when they come in and try to connect them with those.
Follow up?
Thank you.
Thank you. Any other questions? Senator Schuler?
Thank you, Mr. Chairman. Just to follow up on Representative Barlow, I was interested in knowing just exactly if you had an idea or fairly close to an idea of how many actually have private insurance versus those that have the contracts and so on. Do you have an idea on that? Thank you.
Ms. Somerville?
Mr. Chairman, Senator Schuler, for our community mental health centers, the number or percentage of clients with private insurance is incredibly low, less than 10%, probably closer to 3 to 4% in most of the community mental health centers. Our two largest payers are the state contract and then Medicaid.
Okay. Follow up, Senator? Representative Barlow?
Mr. Chairman, so I guess, saying we have a state contract and Medicaid as our two largest payers, really for me, those are both public benefit payers, one being 50% state funds, the other being 100% state funds. So maybe we should tease that out a little more, because what I don't want to end up is with an access problem for either group, either the state directed state funds or the Medicaid funds. So certain communities are going to have certain challenges, different challenges with that. But I think that's something else at least we need to pay attention to in this discussion about general access. And we rated them lower percentage wise, but do the services actually go away or potentially disappear in certain communities if we don't have, for those other payers, if we don't have a state system that at least supports them at some level. I think that was to Representative Olson's point early in the conversation. Thank you, Mr. Chairman.
Any other questions, members of the committee? Representative Chairman Wilson.
Thank you, Mr. Chairman. I guess then just, and I understand that this was maybe previously under all the contracts, but Andy, could you give us a sense, where our discussion about rural areas. So would I understand correctly that all of the community mental health centers would be providing all of these services? One, and then in how many of the counties would you say that the community mental health center is the only or one of only a few providers in general in that county. Does that make sense?
Mr. Chairman, Representative Wilson, or excuse me, Chairman Wilson. I'm just scanning it really quick to make sure I don't misspeak. But I would say all of the community mental health centers provide these services, although they may be in slightly different forms. So the example would be on right here, it says group therapy. So group therapy in Casper might be a variety of groups. So let's say a women's SUD group as well as a men's SUD group. If you take that up to Crook County, for example, that might just be one group that has to be combined. It might not be the best practice, ideally, but we just don't have the patient volume or the providers to run separate groups. So they might look slightly different in each county, but in general, they have some type of all of these services in all the counties. We've got four counties that I can think of that, have the major centers, where I would consider them large centers that provide a substantial array of services. The rest of the counties, again, it varies county to county. I think we've only got maybe 2 or 3 counties that are really sparsely populated, where the community mental health center is truly the primary provider. We don't have any counties where there's not other providers. Again, I apologize for picking on the northeast corner of the state, but that's a smaller population. There's just not enough. There's just not enough clinicians. We certainly face, and the community mental health center, we certainly face recruitment issues with clinicians in our rural counties. And so that's an issue that I believe extends to private providers as well in those counties. So there's not any county that doesn't have another private provider in it. Representative Wilson, if that answers your question.
Thank you. Any other questions? So Andy, I've got I guess a question going back to just, and I appreciate the document because it kind of gives us an idea, but I'm not certain completely how applicable the services currently are. Oh, you took your screen away from me.
Oh, I apologize.
Can you put her back up? And
Yep.
You mentioned that we referred to early intervention, but I think our reference to early intervention is certainly different than what you had in here, which would be almost the Part C, birth to 5 years old, birth to 3. And that really has been delineated now to our community development centers around the state. Then as I look at the medication management and monitoring, and then look at those, if that's an expectation, there's certainly some gaps in that as to those services being provided in our system now, particularly as we see in Bighorn and Hot Springs County, and then some in the substance abuse management of medications doesn't exist at all. And so I'm just saying, I don't know if that's just not required in contract anymore, or if this document provided, even though it is kind of a definition that has been there for some time, and maybe the community mental health centers rely on it. I'm just not sure. Do you feel it's as accurate as it needs to be? Or help me understand how much credence you're putting on this as a critical document for us to consider.
Thank you, Mr. Chairman. I think that's a great point. So this document is fairly old. I would say 8 to 10 years at a minimum since it's been in contract language for the community mental health centers. It certainly does need some updating. As Mr. Chairman, you pointed out, early intervention, birth to 5 years. There are some that are probably still involved through their prevention coalitions, but as you stated, it's been moved over to a different branch under DOH. So there's not maybe quite a bit of that going on. And we think of intervention more, I guess, early intervention in terms of suicide prevention, suicide awareness, mental health awareness, programs like mental health first aid. So in general, this document needs some updating to reflect kind of the needs that have arisen and pieces that community mental health centers have picked up in response to their community need, or maybe have flown out, kind of gone to other agencies or not needed. Specific to medication management and monitoring, that's kind of twofold, both in the mental health side, as you guys discussed earlier today, trying to keep somebody on their meds is an important part of the program. And each center has different resources. A center in one of our larger populations has more resources to be able to put towards that than maybe somebody in the center part of the state in a rural county. And I think those are important ongoing discussions in terms of what those services are and how we're providing those, and if there's major gaps that we need to address. And I would also say that's also true for SUD and medication management as well.
So, well, and I guess the point is if this was if this language was under a current contract, then it would reflect, it reflects back on the services currently being provided. And so then my follow-up question is I believe that in the current contracts, you have an attachment C that really does define what a community mental health center is. Do you have that available?
Oh, Mr. Chairman, I apologize. I don't think I've got the current attachment readily available, but I'd be happy to grab that and send it out to the committee.
Wouldn't that be the better definition to use if that's the current one?
I think that the definition in general is a little bit more streamlined in the current contracts than the ones that maybe are reflected on this particular document. There's certainly, we refer to those more as contract deliverables. And with this document, we think of this more as an all-encompassing kind of to show what a community mental health center brings and what they do. So I don't think there's a ton of difference necessarily. I think this document just provides maybe a more holistic view than the deliverables in the contract.
So then of my fun, and I guess to my point on that, Andy, is it's just trying to understand current versus old. So I think it would have been, it's helpful to be on the same page where you are currently. As you looked at the our exercise, and as we use some percentages on those populations we identified, and I know that you're you and you don't have the input of members, and I respect that, but was there anything that stuck out there that and surprised you, or do you feel that that's kind of in line with where you would expect a state contract to apply priorities?
Thank you, Mr. Chairman. I think in general, I think that it's not unexpected. I think there's certainly a reflection of the conversations we've been having over the last couple of years about the justice involved population and what services they need and how that impacts the entire system. And I think that might have been different than it was a number of years ago, but nothing that really surprised me. As I indicated in my earlier comments, the only thing that I wanted to make sure didn't get glossed over was that general access piece and how we get people in the door for their first assessment.
Okay. So I guess my final question, and of course, the committee may have some more too, is if we went based on the conversation we've had with WAMSAC and the ambiguity in the statutes and defining responsibilities for the community mental health centers, and we started looking at those statutes and identify how we bring these areas that we've identified in your exercise and our exercise into being identified statutorily. Is that concerning, or you think that's the first an appropriate first step?
Thank you, Mr. Chairman. I think that our members have had a lot of conversation about where the appropriate place for defining what we're really talking about, we talk a lot about these priority populations and what populations we should serve, but we're generally talking about eligibility. Who is eligible for state services and how much of state services are they eligible for? We see some pros and cons to putting language in the statute. The con that we're concerned about, or I guess I'll start with the pros. It certainly provides concrete guidance to your community mental health centers on kind of what the expectation of the state and what the priority of the state legislature is for providing services. The con is that as we kind of go along and items change, we've generally couched this in the Department of Health, and they certainly have more flexibility at an executive branch level to make changes year to year on who's receiving services or what programs are important based on kind of current conditions on the ground. And so we want to make sure we maintain some of that flexibility so that as things change. So we find, for example, maybe in the next year or 2 or 3, our suicide prevention, all of those pieces that we're putting in together, maybe that's a really successful program and we can shift some resources over. If that's highlighted in statute as a top priority, then we may not have the flexibility to do that. We may see changes in how DOC or justice involved clients are served. Maybe that evolves and turns into something outside of the community mental health centers in the future, or more DOC driven. That's a conversation that surfaced a few times. Again, we just want to maintain that flexibility to address those current concerns, if that makes sense, Mr. Chairman.
It does. And so I'd ask you a question is so if we, and again, my question is this a reasonable first step? And your point to eligibility, I think, is really a critical one that really warrants additional discussion, maybe is based on how we get the statutes in line, then determine how eligibility is maybe in the next interim. Is that seem like a reasonable approach?
Mr. Chairman, I do think that's a reasonable approach, and I think it's a really important part of the conversation. So if we make some statutory changes this session, kind of in line with your priorities, and we preserve some of that flexibility through and discuss eligibility, whether it's, I would assume it would be couched at maybe a Department of Health level. I think that makes some good sense. And can I give you, Mr. Chairman, can I give you an example of one of the discussions we've had? If you promise not to hold me to it quite yet, in terms of eligibility, maybe it's a conversation with Department of Health about everybody comes in, and if you meet these criteria, you're eligible for 3 visits, and then we have to refer you out to other community resources. So it becomes kind of almost a level of service conversation instead of just a population conversation.
Well, I think you guys are certainly the experts in understand that what we're trying to do is not to much clip your wings, but just say, how do we use the resources that we have to better serve the state? And so we want to do that. I was a little, you mentioned the suicide. Can we fund that under public health, do we not?
Mr. Chairman, generally, yes. There are that was separated out to the public health division. Most of our centers are involved in some type of prevention programming with their coalitions. I think we discussed that at the last labor health meeting, if my memory is not too fuzzy. They are involved in it. It's a significant piece of what they do in terms of community outreach and programming.
Okay, very good.
Mr. Chair, Mr. Co-Chair.
Mr. Co-Chairman, please.
A follow-up, Andy, I just want to make sure that I want to make sure I understood what you said. So, correct me if I'm wrong. What I thought I heard you say is, rather than the legislature outlining, getting too specific, you would feel better if there was greater flexibility for the department working with the centers to determine those priorities, which may change. So I interpret that, looking at this sample of a contract here, which lists a whole host of services and says serve everybody. How would you feel if, and I'm not saying don't hold me to this, I'm not saying I would advocate this, but how would you feel if we as a legislative body said, okay, in priority order, here are the priorities department in terms of what dollars we give you for community mental health centers. And we rank ordered them 1, 2, 3, 4, just like we did in that earlier exercise. And then the department doesn't necessarily tell each center, here's all the range of services you're going to offer to everybody. The department says, well, with the bucks we've got, which is going to be probably a third less than, you know, given the state's revenue, let's theoretically say it's a third less than you've got now or did have. The department works with you to say, here's how we're going to address those priority populations, and everything below priority 4 just maybe gets a visit or two to assess, and that's it. You'd rather do that than us just being very specific as to any more specific than the approach than that?
Ms. Somerville.
Thank you, Mr. Chairman. Senator Kinski. In general, that's been the collective discussions of all of your community mental health centers is where do we put that? How do we balance getting clear direction versus balancing flexibility? And I think you've kind of hit it in terms of trying to keep the statutory, maybe statutory changes 30,000 level foot, and then let the department have flexibility on how they implement those. I don't think there's anything necessarily bad about identifying some high level goals, or not goals, I apologize, high level priorities in the statute, and then give that flexibility down to the Department of Health. And one reason that comes to mind in particular is, as we've discussed a little bit before, every community is different. And so we do have some concerns about imposing kind of unilateral, you will serve these people only under the state contract across the state. Some of our smaller rural centers, to be very honest, just don't have the population to be able to cut out maybe all of the general access and still keep that center financially sustainable. That's something that requires a lot more discussion as we kind of go along, as we talk about that rural access piece. So again, I think that flexibility with Department of Health may be pretty important.
Let me ask a follow-on, Mr. Co-Chair.
Please.
If I may, Andy, what percentage, if these community mental health centers are like the schools, the small ones, the rural ones, are 3 or 4% of the total budget, and the real money is being spent in the larger population centers. Is that true of the community mental health centers too?
Mr. Chairman, Senator Kinski, in general, you will see that type of contract differential between the contracts for the services that are in the larger counties versus the smaller counties. There's certainly a significant amount, a difference in dollar amount. I don't know that it's exactly the same as the schools, but there certainly is a difference in dollars being put in.
Thank you, Mr. Co-Chair. Thank you, Andy.
So Andy, I'd like to follow up, if I may, with the question from the conversation you and Co-Chairman Kinski have had. And it's a little bit of the cake and eat it too scenario, because over the years that I've been in the legislature, one of the big complaints we've had from the community mental health providers is that Dagburn Department of Health, you know, they don't have any oversight. And so they run amok and put all of these requirements in our contract and don't fund it. And you know, they're the Simon Legrees of mental health administration, and we need protection from them. And then now I'm hearing you saying, whoa, don't get carried away, because we want the Department of Health to have flexibility there to allow us to do some things. And so, you know, in fairness to that conversation, I think that there's some, am I appropriate in my thinking, or am I out of line in saying that we need it? It's not priorities as much as define what our policies are, which would reflect the type of populations that we think that these state dollars should cover.
Mr. Chairman, I think that that's an important point to make in terms of how the relationship has changed. We certainly have conversations, ongoing conversations with Department of Health all the time about specific things in the contract. You know, I'll give one example is all of our centers are required to report all of their patients regardless of pay source. So their private pays, their insurance pays, their Medicaid, all of that into what we call the WCIS system, which is the system that was designed to take information about the state paid clients. So we do all of that data entry, but there's a question about, you know, are we being compensated for it? There's differing discussions and ongoing discussions with Department of Health. In general, in the last year, we've had really great discussions with the Department of Health moving forward. And I think part of that is just, again, having those discussions and being more open and honest with Department of Health about the situation on the ground, what that truly looks like. Now, I apologize, Mr. Chairman, I can't speak to the dynamic before about 18 months ago, but I have heard those same concerns. And what I can tell you today is that right now they don't exist currently. Now, whether that's a further discussion about what kind of sideboards you put on that potential so that maybe it doesn't matter who's in the seat at the time. These are kind of the sideboards for those discussions. I think that's maybe something to discuss, but right now we feel pretty good about being able to have those conversations with the Department of Health.
Very good. Thanks, Andy. It's important that we have your input in this as we move forward, you and counseling and all of those that are participating in that. So any other questions before we close public comment? I'm scanning my committee here. Andy, thank you very much. So I think, Mr. Chairman and members of the committee, what I'd like to do is I'd like to take the documents that Department of Health will get cleaned up for us, and then have our LSO staff look at those and compare them with our current statutes and say, if we were to say, these are the required, this is, and we can play with the language, but our policy as a state is these are the populations that we're focusing on with the appropriation for mental health. Is there anybody that feels we're premature on starting to have that discussion? And if so, what, you know, I'm open to that. I don't know that, I think that then we could come back, maybe have a look at kind of what we've found out, but I would like to get, if we're going to move something forward for an initial approach to this, Mr. Chairman, I'd like to get it back before Chairman Wilson and Chairman Scott's committee before their next meeting in October. So if you're okay with that, is there?
Mr. Co-Chair?
Yes, sir.
I just speaking for myself, I think that's a fine approach. I think we've heard from the department, they'd appreciate more clarity in the statute, which is a broad mandate to serve all. You've heard it from the providers that they understand the budget situation and they'd appreciate some clarification in the mandate. It's all in how we do it, and what we heard them say, I think, is do it, but do it with a very deft pencil. And so I think the sooner we get something in writing in front of us, the sooner we'll be able to find out whether we've got consensus from the department and the provider community, and also to see whether it's even going to impact the budgets at all. I suspect we could prioritize those populations. If you took the priority of populations that we came up with, just the first four is probably already 90% of their budgets. I don't know how much potential there is to save.
Okay.
But we'll see.
Senator Guru, please. Oh, you just waving at me? Okay. So John and Elizabeth will clarify that up a little bit, move forward, and then come back to the committee with some of these suggestions and see if they're comfortable with moving that forward to after next discussion, moving it forward to the Labor and Health Committee. So I think if we could let Mr. Petrie in, we're at that point where we'd like to go over the Department of Health's agency budget cuts and take public comment on that too. So we have Mr. Petrie and Franz. Welcome back.
Mr. Chairman, this is Stefan. I think Matt, I do see him in the meeting. If he can certainly answer any questions that you all might have. If you'll let me share my screen briefly here.
Okay.
Our mental health related budget cuts really fall on a few areas. Let me know if you can see my screen, Mr. Chairman.
We can.
Okay, very good. So what I've done here is just highlighted what I totaled is about $6.8 million in this first directed round of budget cuts that are mental health and substance abuse related. What I want to point out here that you'll see on the document that most of you should have, Table 5 of our budget reduction plan. In the Division of Healthcare Financing, really in the Medicaid space, you can see various areas of mental health related budget reductions that do have some impact on community mental health and substance abuse providers, as well as the larger market of reimbursed behavioral health providers that accept Medicaid clients. So what you'll see here on the first line is our kind of across the board rate reduction to most provider types. The only provider types that were really exempted here were those that have federally set reimbursement rates. And so generally speaking, across hospitals, clinics, behavioral health providers, most providers have received a 2.5% reimbursement rate reduction. Out of that $11.3 million of general fund that generates, we estimate around 600,000 of that would be of Medicaid rate reductions would be related to behavioral health. Now, that doesn't mean that that's all allocated to community mental health and substance abuse centers. As I mentioned, there's a much wider market or enrolled provider network of behavioral health providers in Medicaid than just the community providers. Secondly, Mr. Chairman, we have implemented or will be implementing, and many of these require CMS approval or authorization, a service limitation on behavioral health for youth. Again, this will operate similar to the adult service limitation. It's not a hard cap. It's essentially after a certain, in this case, 30 visits on the outpatient behavioral health side, a demonstration of medical necessity will need to be completed. These types of utilization controls give us a little bit more flexibility than just slashing rates. Obviously, we have to do that in a budget reduction of this magnitude to reduce reimbursement rates, but a utilization control allows us to minimize that impact a little bit while also giving providers the opportunity, again, not always popular, but the opportunity to demonstrate medical necessity. Finally, we are changing just a coding issue in Medicaid for behavioral health therapy from 15-minute units to a per session unit. Kind of matches the national standard on coding requirements. We estimate about $1.5 million in general fund savings there.
So can I go back to those caps, the 30? How many? And I don't want to take a lot of time there, but if you can help me, you're saying that that's not a firm cap, that then they come back and can have, for all intents and purposes, a prescription to request additional caps, and that can be for maintenance as well as for rehabilitation. Is that correct?
Mr. Chairman, that is generally correct. So this would act as, for lack of a better term, a soft cap. So essentially a provider would, and I'll oversimplify it, would fill out a medical necessity form that then gets reviewed by the department or the department's contractors to determine if medical necessity is there. That's, like I mentioned, similar to what was implemented on the adult side. On the adult side, last year, or maybe late the year before, we did move that from a 20 visit limit and again, the limit is not hard, it's just medical necessity would need to be determined after 20. We moved that up to 30. And now with this first round of budget reductions that we've been directed to implement on the adolescent side, there will also be a similar process at 30 visits.
So in some of the families that I'm sure members of this committee have heard from, and I certainly have, one of the questions that comes up is did the department consider allowing some flexibility in shifting some of the resources in their plan? For example, if they felt that they would rather have more ongoing maintenance physical therapy rather than respite services, could they shift some of those dollars that are in essence designed to provide respite services over to provide some of the other therapy services? Is that possible, or is that, tell me, answer that, please.
Mr. Chairman, a good question. I think we might be talking about two separate things, and I'm happy to follow up with our folks at Medicaid and get back to you in the committee. Essentially, what I believe you're talking about is more on the waiver, home and community-based service side, where there are budget amounts that are set, as opposed to this, which would be mostly in state plan. So kind of on a fee-for-service basis, what utilization controls or rate reductions are happening. So this would be more in that second bucket. But in terms of behavioral health services specific to our waiver clientele, happy to get some more detail and follow up with you. I just don't have it in front of me.
Yeah, if we could do that, and you're right, it is on the waiver side. If we could follow up with that, maybe on another conversation, I appreciate it.
Sure, will do.
Continue, please.
So moving on away from the healthcare financing division, just wanted to give the committee, again, when we at the department talk about behavioral health reductions, we can be talking about the behavioral health division or larger behavioral health reimbursements that we make, which often include Medicaid. So wanted to give you an overview of the mental health or behavioral health related cuts in Medicaid. In terms of the behavioral health division specifically, and I'm glad I have Matt Petrie on the line to answer any specific questions, you can see kind of 4 high level categories where cuts were made. Again, for a variety of reasons, the Department of Health and the Governor's Office did largely minimize reductions on the behavioral health continuum, including community mental health and substance abuse services in this first round of reductions, as well as the 2 behavioral health state safety net facilities, the state hospital and the Life Resource Center. But you can see some cuts both in the court supervised treatment area, the recovery supports area, some position eliminations, and the elimination of the respite care program. And again, all across the board, so department-wide, healthcare financing and behavioral health division included, I estimate around $6.8 million of general funds that came out in this first reduction. Obviously, in Medicaid, that comes with basically matched federal funds that would also be foregone. So happy to answer any questions from the committee, or Matt, if you're on the line and I misstated anything, especially in behavioral health division, please feel free to weigh in and correct me.
So, Stefan, going back to our healthcare financing, do they allow, when we go back to your previous slides up a little, or your previous page where you talked about services like physical therapy and stuff like that, I thought most of that was just allowed for rehabilitative and not for ongoing. Does that change in Medicaid? Am I misunderstanding that?
Mr. Chairman, I'm not sure I fully understood the question. That's totally on my end. Would you mind repeating it?
No. So my understanding generally is in somebody receiving services, health services for children, that most of that, or that they allow for rehabilitative services, but not for maintenance services. Is that
Mr.
correct?
Chairman, I believe that's generally true, but I don't want to get out ahead of my Medicaid skis. Let me note that as the second item to follow up with you on.
Thank you. Because what we're talking here is if I'm seeing stuff that we would have some ongoing maintenance services, and I'm just wanting to make sure that doesn't conflict with what our policy actually is.
Mr. Chairman, again, I believe on the home and community-based waiver side, that's generally where you find more allowance of habilitative services. But let me get you a more thorough breakdown so I don't misspeak.
Thank you.
Mr. Co-Chair, Senator Schuler is trying to get your attention.
Senator Schuler, you have my full attention, please.
Thank you so much, Mr. Chairman. I just needed a clarification, if I could, from Stefan, mainly on the respite care, and maybe I might be misreading it. Is that just for the birth through 2-year-olds, or do we eliminate all respite care programs? Thank you.
Mr. Chairman and Senator Schuler, I'll let Matt weigh in on that. The respite care program, I believe, is separate and distinct from the early intervention, the developmental preschool program. But Matt, do you have information there?
Thanks, Stefan. Thank you, Co-Chairman Larson and Senator Schuler. Stefan is correct in that I think what you may be referring to is the early intervention and education program, which is essentially broken into 2 sub-programs, one that serves children birth through age 2, and then the other that serves children ages 3 through 5. The respite care program was entirely eliminated. It had a biennial budget, entirely state fund of $144,000, and that was eliminated. There were, of course, cuts as well to the early intervention and education program, and those cuts primarily affected the contracts for the child development centers for the younger children in that age group, ages 0 through 2.
Okay, follow up. Senator Schuler, trying to look for you. We good? Okay.
Mr. Chairman, that concludes the presentation of our behavioral health related budget reductions. I will mention that as part of this reduction package, we will be implementing a rate reduction for the 21-22 biennium in our Title 25 per diem reimbursement rates. So that will come down. We're working on the implementation, likely effective January 1st, from 677 per day to 610 per day. We're hoping that a lot of that could be offset by the capacity we're going to increase at the state hospital with the new facility. Again, another reason that largely the state hospital, the Life Resource Center, with a few exceptions, were exempted, so to speak, from this first round of budget reductions. That does make it harder in other areas. So for example, with a directed 9% cut and the 2 facilities and mental health substance abuse largely being unscathed with a few exceptions, that caused us to cut heavier elsewhere, both in healthcare financing, the director's office, and the aging division absorbed far more than a 9% cut. So we tried to be strategic with these, especially on the behavioral health side, knowing that multiple committees, including this one, were looking at the performance and the missions of these systems, and didn't think it prudent, if we could all avoid it, at least in the first round, to really alter the financing before some of these larger policy decisions were made. But happy to answer any further questions, Mr. Chairman, but that concludes our presentation.
Committee. I'm looking. Thank you. All right. Any public comment scheduled for this portion of our meeting, Elizabeth?
Sir, I did not have anything noted for this particular item.
So committee, Mr. Co-Chairman, we're at 11:48. We're ready for Department of Family Services. Would you care to break for a little bit of lunch? Or do you want to plow through?
I'll defer to the group. I could go either way. I have the day blocked. Anybody have any strong feelings about taking a 30-minute break? Against or for?
I think we have to take a break anyway to, if memory serves me correct, John, Elizabeth, you can let me know. I think that's our agreement with on our technology side, that we have to take a 10 or 15-minute break if we go into the afternoon.
Well, I think 30 minutes. Let's just take a 30-minute break then, Lloyd. I think that works.
Let's just come back at 12:30.
All right, thanks, sir.
Sir,
Yes, ma'am.
For those members who are watching the meeting on the public, we will have a different YouTube stream. For all the members, you will use the same link and stay in the meeting, just so the public is aware that they will have to find us again on the same LSO webpage.
That was correct, that we needed to do that break. Is that not correct, Elizabeth?
Yes, sir, that is appreciated when we take a break between the two streams.
Okay, thank you.